Hi, everybody. So, today our topic of discussion is one of the most important topics for NEET, PG, and FMG and any other competitive exam, and that is amenorrhea. Okay? So, here also, like our last lecture, किसी भी चीज़ की डिटेल में नहीं जाना है. By this time, you already know the details. We will basically revise what we know and we'll correct some of the facts which I think which are the confusing one. ठीक है? Okay. I'll just share my screen. Yeah. I think it is visible to everyone. So starting with amenorrhea. Okay? Let's start with the definition. Let's start with the definition first. Oh God, I'm not able to. Just give me a second. What is the definition? The first question comes on the definition of amenorrhea. Let me set this up. So what is the definition? Now it is a new revised definition. पहले ये age criteria was 14, 16. Now it is changed. What is the new definition? If a girl does not get menses and no secondary sexual characters, तो दोनों चीजें नहीं आई हैं. Neither menses nor secondary sexual characters by age of 13, or in case she gets the secondary sexual characters, then we can give her a leverage of 2 more years. अगर उसको secondary sexual characters आ गए हैं, we can still wait for 2 more years, and even after age of 15 years she does not get her menses, then that is a case of primary amenorrhea. So remember these numbers 13 and 15. ठीक है. What is secondary amenorrhea? Secondary amenorrhea means a woman who was menstruating previously, and one fact is very obvious: if she was menstruating, secondary sexual characters will be there. So a woman who had secondary sexual characters, she was menstruating. Now she is not menstruating since 3 previous cycles. अगर उसकी cycles regular हैं, then since 3 previous cycles she is not menstruating. और अगर cycles irregular हैं, तो since previous 6 months. ठीक है. Then we'll call it secondary amenorrhea. Going ahead with WHO classification, WHO has classified amenorrhea, both primary and secondary, into 3 categories. Recently, a 4th category we add here. We'll discuss that. Group 1 is hypogonadotropic hypogonadism. So, understanding that, we need to know that how HPO axis work. कैसे काम करता है? देखो, hypothalamus होता है. This hypothalamus secretes releasing hormones and influence the pituitary. This pituitary in turn secretes FSH and LH, and that goes and stimulates ovaries. This ovary secrete estrogens. That is the cause for, or that is the hormone responsible for secondary sexual characters and also for menses. So it will affect the uterus and peripheral organs. So can I divide this into 3 compartments? 1, 2, and 3. So if there is some defect in compartment number 1, what will happen? Either hypothalamus is affected or pituitary is affected. What will happen? Let me use another color. The gonadotropin levels will fall. Gonadotropin levels will fall. Since gonadotropin levels will fall, ovary will not work. The patient will not have secondary sexual characters. She will not have menses. इसे हमने कहा hypogonadotropic hypogonadism. Gonads मतलब ovary not working and gonadotropin levels are low. Second, if there is a defect, straight away come to third first. पहले 3 देखते हैं, group 3. So if the defect lies in compartment number 2, that is in the gonads itself. If there is some problem in the ovary itself, what will happen? Then ऊपर gonadotropin is functioning fine, Only ovary is not functioning fine, resulting in decreased estrogen levels. So estrogen levels are decreased. Women will not have secondary sexual characters. She will not have menses. But this time, what will happen? Gonadotropin levels will be high. Why it is high? Because estrogen is so low कि वो जो negative feedback था, that is gone. So इसको हमने कहा हाइपर गोनाडोट्रोपिक हाइपोगोनाडिज्म. सो रिमेंबर, जब भी आपको FSH LH की वैल्यूज हाई मिलेंगे, द डिफेक्ट लाइज इन ओवरी. जब भी FSH LH लो मिलेंगे, डिफेक्ट लाइज समवेयर इन द सेंटर. ठीक है. तीसरा होता है नॉर्मोगोनाडोट्रोपिक एनोकुलेशन. That is mainly a cause of secondary amenorrhea. A woman who used to menstruate, now she is not menstruating because of some disturbance in HPO axis. It is functioning fine. Hormone levels are normal. Due to some problem, there is HPO axis disturbance resulting in anovulation. बस women ovulate नहीं कर रही है. Ovulate नहीं कर रही है तो she is not having menses. Secondary sexual characters present है, gonadotropin levels normal है, estrogen level normal है. That is category 2. Primary amenorrhea basically lies either in group 1 or in group 3. ठीक है. Going ahead, starting with primary amenorrhea. What was the definition again? Women or girl not menstruating, not having secondary sexual characters even after 13 years, or if she has secondary sexual characters, not menstruating even after 15 years. Okay? The defect can lie anywhere, in the center, in the gonads itself, ovary itself, or in the uterus. Talking about the center. So when the problem lies somewhere in the center, the hypothalamus or pituitary, very, very obvious it will be hypogonadotropic. Hypogonadotropic hypogonadism. Does that mean the FSH LH values are low? Yes. If FSH LH values are low in a very young girl, जिसका HPO एक्सेस अभी सेट भी नहीं हुआ है ना? If the FSH LH are low, ovaries will not function. Does that mean her secondary sexual characters will be absent? Yes. What can be the causes? The most common central cause. So most common central cause is physiological delay. There is no problem in her. It is just a physiology. She will have a delayed menses and delayed secondary sexual characters. It's just a physiological delay. Second most common central cause. ठीक है, मैं second most common cause नहीं बोल रही हूँ. Second most common central cause is Kallmann syndrome. Kallmann syndrome is when the neuronal migration, जो hypothalamic neurons है बनते हैं आपके, it basically forms in the olfactory area. So when neuronal migration from olfactory placodes to hypothalamus does not happen, it results in primary amenorrhea. Characteristic feature: patient also have anosmia. The patient is not able to smell anything. ठीक है. Other central causes are uncommon, which we don't need to remember all the time. Other central causes are like, जैसे if there is a trauma, if there is some cyst, they are uncommon causes. Coming to compartment number 2, if there is defect in ovary, what will be the hormonal manifestation? That will be hypergonadotropic. Remember, gonadotropin levels will be high. Why? Because estrogen is so low, there will be negative inhibition. So hypergonadotropic hypogonadism. Since hypogonadism is there, gonads are not functioning, estrogen is low, again secondary sexual characters are absent. Yes, secondary sexual characters are absent. What is the cause? The most common cause is she is born with defective gonads. उसके gonads बने ही नहीं है. So something which has not formed properly, उसको हम क्या बोलते हैं? Dysgenesis. Something has not formed properly. So इसे हम कहेंगे gonadal dysgenesis. Gonadal dysgenesis is the most common cause of primary amenorrhea overall. So overall, if you see, what is the most common cause of primary amenorrhea? Gonadal dysgenesis. Gonads have not formed. ठीक है. Second cause in a young girl जिसमें ना secondary sexual characters बने हैं ना menses आए, can be ovarian failure. Ovarian failure due to surgery or radiation, obviously very common. इतनी young age में कि 13 years पे ovary surgery हुई है या radiation या chemo मिला है, very uncommon. So this is the most common cause of primary amenorrhea. तीसरा compartment, some problem in the outflow tract. center is functioning fine, ovary is functioning fine. Problem is somewhere in the uterus or in the vagina. So, what will happen to the hormones? Uterus does not produce any hormones, right? So, if center is functioning fine, ovary is functioning fine, obviously the hormones are normal. If hormones are normal, does that mean secondary sexual characters are present? Yes. So, this is the only condition where secondary sexual characters will be present. What can be the causes? Causes can be imperforate hymen. Causes can be a vaginal septum. Causes can be कि यूट्रस नहीं बना, जैसे गोनाड्स नहीं बने थे वैसे यूट्रस नहीं बना, तो इसमें भी क्या बोलेंगे हम? यूट्राइन एजेनेसिस. ठीक है, इस सिंड्रोम को नाम दिया गया है MRKH, वेयर यूट्रस हैज नॉट फॉर्म्ड प्रॉपर्ली. So these are the different causes. Which is the most common cause? Gonadal dysgenesis. ठीक है. So amenorrhea with no secondary sexual characters. Going back to that slide, no secondary sexual characters means problem either in the center or in the gonads. So with no secondary sexual characters, let's deal with the center first. ठीक है. So क्या कहते हैं? Hypogonadotropic hypogonadism. Most common cause physiological delay. Second most common cause Kallmann syndrome. Other causes I've already told you. ठीक है. Then the second compartment defect like ovarian defect. Ovarian defect will be called as hypergonadotropic hypogonadism. ठीक है. Most common cause of this is gonadal dysgenesis. Primary ovarian failure enzyme deficiencies are uncommon. But since 2 years, a lot of questions have been asked on rare enzyme deficiencies. It is rare. नाम भी है उसका rare enzyme deficiencies, but questions have been asked, so we will deal with it. Gonadal dysgenesis क्यों होता है? See, these are the normal gonads. Dysgenesis में this is the gonads, like a streak, एक पतली line जैसा, इसे कहते हैं streak gonads. So why the gonads have not formed? Due to some chromosomal disorder. The most common cause of this gonadal dysgenesis is Turner syndrome. Turner syndrome is the most common chromosomal disorder that presents with gonadal dysgenesis. So can I say Turner syndrome is the most common cause of primary amenorrhea? Yes. ठीक है, where one X chromosome is absent and that is why the gonads are streaked. Other causes क्या हो सकते हैं? That gonads, that chromosomes are normal like XX, but still they are not functioning due to some unidentified disorders like ring chromosome, micro deletions. These are some disorders which we just can't catch on karyotype or CGH analysis. So due to these defects, the dysgenesis happen. इसको कहते हैं pure gonadal dysgenesis. Pure gonadal dysgenesis means chromosome was normal XX, still it didn't formed well functioning gonads. इसे हमने कहा pure gonadal dysgenesis. Mosaicism means patient has two type of chromosomal makeup, X0 and XX. This is called as mosaicism. X0 and XX. When because of this mosaicism, patient will have gonadal dysgenesis. Then certain enzyme deficiencies. Enzymes involved in the enzyme involved in steroidogenesis pathways. That is also a reason for gonadal dysgenesis. Turner syndrome. Most common cause of gonadal dysgenesis, most common cause of primary amenorrhea. The chromosome makeup of patient is X0. So initially ovarian development intrauterine is normal, but eventually the accelerated atresia happen, and by the time the girl is born, all the follicles are gone. Turner syndrome, obviously it is hypergonadotropic hypogonadism. मतलब अगर आपको सिनेरियो मिलेगा तो FSH LH will be high, estrogen levels will be low. Estrogen levels low मतलब secondary sexual characters will be absent. Other than that, there are a lot of other stigmata present like short stature, she has webbed neck, low hairline, high arched palate, shield chest, her carrying angle is increased. Carrying angle, ये जो angle होता है between your arm and forearm, this is the carrying angle, that is increased. more of the radial deviation is there. So increased this carrying angle, short fourth metacarpal and multiple nevi. These are the other stigmata that are present in Turner syndrome. Besides that, Turner syndrome में बहुत सारी systemic abnormalities भी मिलती हैं. So when you get a Turner syndrome patient, you have to give a complete evaluation. There are renal anomalies present, horseshoe kidney. There are cardiac anomalies, among which most common is coarctation of aorta. That is also very common. Then autoimmune disorders are common, so you have to keep checking for thyroid disorders, and sensory neural hearing loss. So since all this is common, whenever you see a Turner syndrome patient, you do a cardiac evaluation, you do a hearing evaluation, you keep on checking every year for thyroid and other autoimmune disorders, and you get a renal scan. This all is done in Turner syndrome patient. ठीक है. So let's see. अब अभी तक हमने जो anomalies पढ़ी हैं, let's see how the question will give us. How in question we will search for diagnosis. Turner syndrome. In Turner syndrome, basically internal genitalia is uterus and vagina. ठीक है. Internal genitalia, uterus and vagina क्यों है? Because uterus vagina does not need estrogen. Uterus and vagina is a default system that will be formed in everyone. But males में uterus vagina क्यों नहीं बनता है? Because they have anti-Mullerian hormone. Anti-Mullerian hormone is secreted from testes. So anybody is not having testes will form uterus vagina. उसके लिए we don't need estrogen. So Turner syndrome will have uterus vagina internally. Externally also it will look like a female. Means external vulva presentation will be just, external genitalia will be just like female. But secondary sexual characters will be absent. ठीक है. FSH LH will be high. Coming to pure gonadal dysgenesis, यानी XX gonadal dysgenesis. XX gonadal dysgenesis just like Turner. XX है, but due to some chromosomal errors, estrogen is not formed, gonads are not working. So inside uterus vagina normal, genitalia like a female, but secondary sexual characters absent, menses absent, FSH LH high. You can differentiate between these two only via karyotype. So whenever you get hypergonadotropic hypogonadism, do karyotype because it can be either of these. XY gonadal dysgenesis भी होता है. XY gonadal dysgenesis, again it was XY, but again chromosomal dysfunction resulted in gonadal dysgenesis. था तो testis ही body में, but it was dysgenetic, it was not functioning. So as a result, what will happen? Testis will not secrete AMH, testis will not secrete testosterone. तो जब AMH नहीं है, anti-Mullerian hormone नहीं है, by default the patient will have uterus vagina. I told you estrogen is not needed. So by default uterus vagina will form. External genitalia also does not need estrogen. That will also be female. But secondary sexual characters need estrogen. So that will not form. So though it is XY, but internally and via genitalia it will look like females. क्योंकि internally male structure बनने के लिए, externally male genitalia बनने के लिए, you need testosterone. Testosterone is not there, so everything will look like female. ठीक है. So they all present in a similar way, and the only way to differentiate them is via karyotype. ठीक है. अब आते हैं rare enzyme deficiencies पे. Rare enzyme deficiencies means enzyme deficiencies in this steroidogenic pathway. So this is a pathway that happens in the adrenal glands. This is the pathway that happens in the gonads also, ovary and testis both. It starts from cholesterol and result in formation of all steroid hormones, mineralocorticoid, glucocorticoid, and your sex steroids. Okay, so this is the pathway that is happening in the gonads also. Now, whenever there is enzyme deficiency like 17 alpha hydroxylase deficiency. So 17 alpha hydroxylase is this one. So whenever there is 17 alpha hydroxylase deficiency, what will happen? This cycle, instead of going here, resulting in formation of glucocorticoids and sex steroids, what will happen? It will result in high mineralocorticoids. High mineralocorticoids but no sex steroids. अब gonads तो functional हैं, गोनाड्स का प्रॉब्लम नहीं है. इट इज नॉट गोनाडल डिसजेनेसिस. दैट वाज गोनाड. कैन यू सी गोनाडल डिसजेनेसिस? गोनाड्स नहीं बने. इट इज नॉट गोनाडल डिसजेनेसिस. गोनाड्स बन गए, चाहे वो ओवरी हो या टेस्टिस हो. गोनाड्स हैव फॉर्म्ड. Only problem is that estrogen in females and androgen in males, that is not formed because enzyme is not there. So what will happen? Obviously, internally there will be uterus and vagina. Externally, it will look like female again, because to look like male externally through second through genitalia, you need androgen hormones. If it is not there, by default, the it will result in a female like development. So it will be internally female, externally female, but secondary sexual characters again absent. Menses again absent. So it will look like a female, but menses are absent. Secondary sexual characters are absent. ठीक है? So this was about hypergonadotropic hypogonadism. So gonadal dysgenesis being the most common cause. Another rare cause I told you was primary ovarian failure. It is very rare. इतनी young age में radiation और इतनी young age में some surgery और इतनी young age में some chemo is rare. So primary ovarian failure is generally rare. Primary ovarian failure जिसे हम premature ovarian failure कहते हैं, that does happen, but that is a cause of secondary amenorrhea. हम इसे कहते हैं प्री मेच्योर, समय से पहले ओवरी फेल हो गई है, जिसकी ओवरी पहले काम करती थी, इट फेल्ड बिफोर टाइम, रिजल्टिंग इन सेकेंडरी एमेनोरिया. दैट वी विल रीड देयर. ठीक है? तो जब से हम हाइपर गोनाडोट्रोपिक हाइपोगोनाडोट्रोपिक कह रहे हैं, तो लेट्स सी व्हाट इज हाइपर एंड व्हाट इज हाइपो. नॉर्मल एफएसएच लेवल and LH level is this. So anything less than 5 is hypogonadotropic. Anything more than 20 is hypergonadotropic. Remember, whenever it is hypergonadotropic, problem is in ovary. It is hypogonadotropic, problem is in hypothalamus or pituitary. Okay? So what are the topmost point that we have learned? Most common cause of primary amenorrhea, ovarian dysgenesis. Most common cause of ovarian dysgenesis, Turner syndrome. What other anomalies Turner syndrome is associated with? Cardiovascular, renal, hearing loss, autoimmune disorders. Okay? So when the question gives you these physical stigmata along with high FSH, X0, it's Turner. High FSH but normal karyotype. Turner also have short height. So normal karyotype, normal height, it is pure gonadal dysgenesis. Pure gonadal dysgenesis. अगर streak gonads है तो pure gonadal dysgenesis. अगर normal gonads है तो dysgenesis तो नहीं है. अगर normal है, it is not streak, normally formed है, then it is enzyme deficiency. ठीक है? So what are the classical FSH and LH levels in Turner syndrome? It is high, since it is a gonadal failure. 16-year-old girl present to OPD with complaints of primary amenorrhea. She has height 150, poorly developed breast. On examination, vagina is present. Ultrasound reveal normal uterus, but gonads not detected. So uterus है, but gonads नहीं है. It showed FSH high and karyotype XY. So height is normal, FSH high. हम समझ गए gonadal dysgenesis है. Gonads visible भी नहीं है. But can you see the karyotype XY? तो karyotype तो normal है. It is pure gonadal dysgenesis. ठीक है? अभी androgen insensitivity we will read. Kallman syndrome क्यों नहीं है? Kallman syndrome is a central problem. FSH will be low. Turner mosaic will be X0 and XX. ठीक है? 15-year-old patient comes to OPD with absent secondary sexual characters. You advised hormonal profile, which showed the following values: FSH 6, LH 7, estradiol 10 picogram. So estrogen is less. ठीक है? FSH LH is towards less than 5 is abnormal, it is towards less. So what will you advise? Most likely it is a central cause. We are not sure, but most likely it's a central cause. So what will you advise them? सीटी स्कैन हेड, है ना, मोस्ट लाइकली इट्स अ सेंट्रल कॉज, इसीलिए यू विल एडवाइज सीटी स्कैन हेड इवन इफ इट इज अ कॉन्स्टिट्यूशनल डिले, यानी इट इज अ फिजियोलॉजिकल डिले विच इज द मोस्ट कॉमन सेंट्रल कॉज. तो बिफोर टेलिंग एनीबडी कि आपको तो फिजियोलॉजिकल डिले, वी नीड अ नॉर्मल सीटी. तो अगर किसी को सेंट्रल कॉज होता है तो फर्स्ट वी डू अ सीटी स्कैन. इन केस इट कम्स आउट टू बी नॉर्मल, then we say it is a physiological delay. So CT scan is needed first to say that. So that was primary amenorrhea with no secondary sexual characters, either central problem or gonadal problem. Now amenorrhea with secondary sexual characters present. अगर secondary sexual characters present है, it means उसकी बॉडी में ईस्ट्रोजन तो नॉर्मल है, तभी तो सेकेंडरी सेक्सुअल कैरेक्टर्स हैं. ईस्ट्रोजन नॉर्मल है मतलब एफएसएचएलएच भी नॉर्मल है, बिकॉज अगर एफएसएचएलएच नॉर्मल नहीं होता, हाउ शी वुड इज मेकिंग ईस्ट्रोजन. So FSHLH is also normal. So problem is not in center, it is not in gonad. Problem lies somewhere in the uterus and vagina. ठीक है? So it is either outflow or a Mullerian anomaly. ठीक है? Either it is an outflow or Mullerian anomaly, or one more cause that we will read in detail, androgen insensitivity. ठीक है? तो पहले पढ़ते हैं outflow anomaly. Either blockage है outflow tract में, ये है ना outflow tract. Either there is a blockage यानी menses आ रहे हैं but it is not coming out, और outflow tract है ही नहीं, missing है, this whole tract is missing. ठीक है? So whenever there is a blockage, it means menses are coming but they are getting trapped. So entrapment of menstrual blood resulting in hematometra, blood in uterus, hematosalpinx, blood in tubes, and endometriosis. जब भी reflux होगा तो endometriosis होगा. So whenever there is transverse blockage, patient क्या बताएगा? Cyclical pain. उसको हर बार जब menses आते हैं पेन आता है, but menses नहीं आते. So whenever something is cyclical coming every month, it is related to HPO axis. So cyclical pain है but menses are not coming. Secondary sexual characters भी present है. And when you do local examination, because so much blood is getting collected in the uterus, you will see bulge in the vagina. Vulval bulge will be seen. Because so much blood has collected on the upper way, it is pushing whatever membrane is blocking it. So that's how it presents. Blockage के दो रीजन होते हैं. मोर कॉमन imperforate hymen. Can you see like this? Hymen जो बिल्कुल outer surface है, that is imperforate, that has no hole. Just hold on. हेलो. हाँ हाँ हाँ, मेरा पास नहीं था यार अपना. अच्छा, मेरी भी क्लास चल रही है यूट्यूब पे. हाँ 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 हाँ. ओके. ठीक 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 ठीक. So can you see imperforate hymen? It's a membrane just on the vulva. So here there is no vaginal length. You see a thin membrane, bulging membrane. Bulge क्यों कर रही है? ये thin है. So ऊपर का blood is making it bulge. So it's a bulging thin membrane. ठीक है? No vaginal orifice. You can't see any orifice. Vagina नहीं दिख रहा है, बिल्कुल outer surface पे. It is thin, इसलिए ऊपर collected bulge is looking blue. So blue bulging membrane is imperforate hymen. This patient will have normal secondary sexual characters. There will be cyclical perineal abdominal pain. Patient can also have acute urinary retention. क्यों? क्योंकि why urinary retention will happen in this condition? Because there is hymen. यहाँ पे hymen है और bladder is here. So when it is filled with blood, this upper whole vagina is filled with blood. It is compressing the urethra, resulting in urinary retention also. So simple answer is, as soon as you diagnose, treat it by applying a cruciate incision. This kind of an incision is done. Flaps are opened, and this cruciate incision will result in all the blood, collected blood, letting it out. दूसरा ब्लॉकेज का रीजन होता है ट्रांसवर्स वजाइनल सेप्टम. So this septum is not a thin membrane, it is a thick muscle. It is a thick muscle and it can lie anywhere in the vagina. Hymen was just on the vulva, but this septum can lie anywhere in the vagina. So can you see a small vaginal length? आपको एक छोटी सी vaginal length दिखेगी. What you see is not a thin bulging membrane, but a thick pink muscle, which is not bulging. It is not bulging because it is a thick muscle. So what will you see? A normal, you will see a vaginal, small vagina. You will see a non-bulging pink membrane. A non-bulging pink membrane is vaginal septum. What about secondary sexual characters? This girl will have secondary sexual characters. But again, there will be cyclical pain. Okay? Urinary symptoms might not be present here because if it is a higher, if it's a septum in high in vagina, then it will not lead to compression of urethra. So urinary symptoms might not be a presentation in transverse vaginal septum. Here the diagnosis is you have to excise this and attach a graft. It's a muscle you are excising. So once you excise it, you have to cover it with a graft. Okay? Other causes of blockage है cervical agenesis. Cervix ही नहीं बना, uterus बना है, but the cervix has not formed. As a result, blood is getting collected. So there is a short vagina, but you can't see cervix. You can't see cervix, normal secondary sexual characters, same cyclical pain, cryptomenorrhea जैसे कहते हैं. So how will you diagnose, differentiate between cervical agenesis and transverse vaginal septum? Septum भी तो हो सकता है यहाँ पे. By doing MRI. MRI is the method of choice for differentiating between these two. ठीक है. एक क्वेश्चन आया था that अब देखो 3 presentations है. ये है आपका यूट्रस, ये है यहाँ पे imperforate hymen, blood collected everywhere. This is rectum. Another condition is imperforate transverse vaginal septum. Transverse vaginal septum in 60% cases is high in vagina. ठीक है, कुछ केसेस में लो भी होता है. सो ब्लड कलेक्टिंग हियर. तीसरा है सर्वाइकल एजेनेसिस. सो सर्वाइकल एजेनेसिस में देयर इज नो सर्विक्स, सो ब्लड कलेक्टिंग ओनली इन यूट्रस. नाउ द क्वेश्चन वाज पेशेंट हैज सेकेंडरी सेक्सुअल कैरेक्टर्स, नो मेंसेस, क्रिप्टोमेनोरिया प्रेजेंट. On PR, on per rectal examination, vagina was full. There was whole vaginal fullness. In which pathology the vagina is full? Full with what? Obviously filled with blood. In which pathology you can see vagina is filled with blood? In PR, I'll see fullness in vagina. I can't see vagina is not full here. Vagina is absolutely not full here. But here the vagina is filled with blood. So imperforate hymen is the one where per rectal examination will give you fullness in vagina. So coming to transverse blockage, imperforate hymen and transverse vaginal septum. This is more common. Here you see a thin blue bulging membrane, whereas here you see a non-bulging pink tissue. Urinary obstruction is present. Here generally no urinary complications. You can't see a vaginal orifice. It is just on the vaginal orifice. But here you can see vagina small or maybe longer, but yes, it is visible. Okay? Question. 16-year-old girl presents to OPD with primary amenorrhea, cyclical pain. जैसे cyclical pain देखो समझ जाओ it is something in some blockage. Perineal examination reveal bulge protruding from vagina. Identify the cause. So bulge protruding from the vagina, बल्ज तभी होगा जब वो मेम्ब्रेन थिन है, देन ओनली इट कैन बल्ज. ठीक है. सो द कॉज इज imperforate hymen. A patient comes to your OPD with complaint of again primary amenorrhea. She has well developed secondary sexual characters. No positive family history. How will you follow her? वेल डेवलप्ड सेकेंडरी सेक्शुअल कैरेक्टर्स मतलब एक्सपेक्टेड है कि ईस्ट्रोजन नॉर्मल है और एफएसएच एलएच नॉर्मल है. मोस्ट लाइकली अगर ये प्राइमरी एमेनोरिया है, प्रॉब्लम इज समवेयर इन यूट्रस एंड वजाइना. What will I do? I'll do an ultrasound pelvis. I'll not do FSH, LH and CT scan. So that was about blockage. Now outflow tract missing. Outflow tract नहीं बना है. So अगर outflow tract नहीं बना है, obviously again hormones will be normal. Secondary sexual characters will be normal. है ना? Because the tract has not formed at all. पर क्या cyclical pain will be there? Cyclical pain will be absent. There will be no cyclical pain. क्योंकि cyclical pain क्यों हो रहा है? क्योंकि blood is getting collected every month, इसलिए cyclical pain है. जब blood बन ही नहीं रहा है, blood बनेगा यूट्रस में से. यूट्रस is not there. When uterus is not there, there is no cyclical pain. That pathology is MRKH. Mayer-Rokitansky-Kuster-Hauser syndrome. Second most common cause of primary amenorrhea. Most common cause was Turner syndrome. It is second most common cause. Karyotype normal है, ये girl normal है, इसके gonads normal है. Just that there is agenesis of the genital tract. When many times when genital tract has agenesis, renal tract also has some anomalies. Renal tract में भी anomalies होते हैं. Secondary sexual characters will be well developed. ठीक है. So ये जो हमने चार्ट बनाया था when we started with primary amenorrhea, let's complete it. MRKH. MRKH में no uterus vagina, though she is XX, पर uterus vagina नहीं है because that is the agenetic part. Externally वो female जैसी है, secondary sexual characters भी present है, but uterus vagina is absent. As against gonadal dysgenesis where uterus vagina was present, even when it was XY, it was present. ठीक है. तीसरा कॉज आता है, हमने पढ़ा ब्लॉकेज, हमने पढ़ा एब्सेंट ट्रैक्ट. Third comes in this category is androgen insensitivity. As the name signifies, androgen insensitivity मतलब XY. Androgen ना, तो androgen तो XY में ही बनेगा. So androgen insensitivity means an XY person producing androgen, but the peripheral tissue is insensitive to androgen. It is androgen insensitivity syndrome, also called as testicular feminization syndrome. So testicular feminization. Testis है, but it has got feminized. The person is feminized. और functional testis. Dysfunctional testis को तो हमने agenesis कह दिया था. ये functional testis. जो peripheral tissue है, that is androgen insensitive. How will it present? It's an XY person, but everything was androgen insensitive. As a result, अंदर क्या बनेगा? अंदर will there be male genitalia formation? Male genitalia को testosterone चाहिए. Testosterone तो है, but the receptors are not there, so male genitalia will not be formed. क्या यूट्रस वजाइना बनेगा? फिर यूट्रस वजाइना को तो एस्ट्रोजन नहीं चाहिए ना. यूट्रस वजाइना will form? No. Testes are functional. Anti-Mullerian hormone is being produced. Anti-Mullerian hormone तो produce हो रहा है. So because of anti-Mullerian hormone, uterus vagina will also be absent. So there is no Mullerian duct structure. There is no vast difference and male genital structure. There is nothing inside. Externally वो female जैसी लगती है, genitalia female जैसा है, but अंदर से uterus vagina नहीं. Secondary sexual characters that will be by default present. क्यों? Because testosterone इतना high है in male range, this testosterone will go and convert into estrone in the peripheral fat. वो peripheral fat में estrone बनाएगा, that will result in breast development. Not like a normal female, थोड़ी ill developed breast होंगे, but breast development will be there. So though it is androgen insensitivity, are you getting it? अंदर ना female structure बन पाया ना male. Genitalia तो female है, क्योंकि उसको टेस्टोस्टेरोन जो चाहिए था वो insensitive है. So external genitalia is female, but secondary sexual characters are present. Means breast is present because it is converting to estrone. One very characteristic point which is always mentioned is questions is scant and absent axillary and pubic hair. That is absent. क्योंकि axillary and pubic hair आपने puberty में पढ़ा होगा, pubarchy, that is an action of androgens, adrenal androgens. और ये syndrome है androgen insensitivity. तो वो एंड्रोजन एड्रिनल ग्लैंड से है या टेस्टिस से, इट डजंट मैटर. द टिश्यू इज इनसेंसिटिव. दैट इज व्हाई देयर आर नो pubic and axillary hair. Breast is developed, immature but developed. ठीक है. एक्सटर्नली इट लुक्स लाइक अ फीमेल. ठीक है, जेनिटेलिया, बट वजाइना इज शॉर्ट, क्योंकि अंदर यूट्रस है ही नहीं ना. तो शॉर्ट जो जो वजाइना सिर्फ यूरोजेनाइटल साइनस से बन गई है, बस वही बनी है. अंदर मुलेरन डक्ट नहीं है, तो देयर इज नो वजाइना. तो ब्लाइंड वजाइनल पाउच, एक छोटा सा वजाइनल पाउच विल बी देयर. So if I add here androgen insensitivity, no uterus vagina, looks like female, breast developed. So just like MRKH, no uterus vagina, looks like female, breast present. How to differentiate? Always karyotype. So whenever you want to differentiate between these two, karyotype. One is XX, another one is XY. So missing genital tract, two reasons. MRKH, androgen insensitivity. MRKH is second most common cause of primary amenorrhea. Androgen insensitivity is third most common cause. Secondary sexual characters present in both of them. But differentiating point, MRKH XX है, normal female level testosterone है, ठीक है, and pubic and axillary hair are present. Androgen insensitivity XY है, male level testosterone है, and pubic and axillary hair are absent. ठीक है, चलो. A 16-year-old, so we are running out of time also. I think we'll finish only primary amenorrhea, and next class we'll do secondary amenorrhea. 16-year-old female with well-developed secondary sexual characters. जैसे ही आ गया, I know problem is not in ovary or in hypothalamus. Ovary as internal gonad, ये भी दे दिया उन्होंने. Absent uterus vagina, तो absent uterus vagina तो दो ही cause थे, MRKH and androgen insensitivity, but they have given ovary. Androgen insensitivity has testis. What is the diagnosis? Mullerian agenesis. MRKH is also called as Mullerian agenesis. A young female present with primary amenorrhea, normal breast, but absent axillary hairs. Pelvic examination show normally developed vagina with little clitoromegaly. Vagina है, छोटी vagina है, but clitoromegaly है. On ultrasound, gonads are visible in inguinal region. So जो भी gonads inguinal region में दिखते हैं, remember gonads in inguinal region is always testis. Ovaries are always abdominal. Ovaries कभी भी inguinal region में नहीं होती. So gonads in the labia or gonads in inguinal region is testis. So that is why it is XY. तो क्या ये androgen insensitivity है? Definitely. गर्ल जैसा दिख रहा है, नॉर्मल ब्रेस्ट डेवलपमेंट है, बट क्लाइटोरोमेगाली है. एंड्रोजन इंसेंसिटिविटी में तो बिल्कुल टिश्यू इज इनसेंसिटिव टू एंड्रोजन. सो क्लाइटोरिस कैसे बड़ा हो गया? सो इट इज पार्शियल एंड्रोजन इंसेंसिटिविटी. दैट इज व्हाई क्लाइटोरोमेगाली इज आल्सो प्रेजेंट. Which of the following is the best explanation for breast development in androgen insensitivity? Gonad is producing estrogen? No. Adrenal gland producing estrogen? No. Breast tissue sensitivity to progesterone? Peripheral conversion of androgens to estrone. That is resulting in breast development. So whenever you see a primary amenorrhea patient, always look for secondary sexual characters. If it is present, it is a uterine or vaginal cause. You will go for ultrasound. If secondary sexual characters are absent, either center or gonadal problem is there. I'll do FSH and LH. If FSH LH is high, I told you if it is high, it is always ovary. If it is low, it is always center. If it is an ovarian problem, I know it is gonadal dysgenesis. But what is the cause? I don't know what is the reason. I'll get karyotype. If it is a central problem, I'll get a CT scan. ठीक है. Remember Turner syndrome, इस पे भी क्वेश्चन आया है. If a patient has Turner syndrome, besides evaluating her for everything else, you will evaluate thyroid function, you will do echo, renal ultrasound, fasting lipid profile, and audiometry. This is the evaluation that is needed in a Turner syndrome patient. So we have completed our 1 hour. Primary amenorrhea is finished. Let's just quickly see the treatment. If there is hypergonadotropic या hypogonadotropic hypogonadism, यानी ओवरी की प्रॉब्लम है या सेंट्रल प्रॉब्लम है, गोनाड्स आर नॉट फंक्शनिंग, ईस्ट्रोजन इज लो, what will be treatment? Obviously, give her hormonal therapy. Give her cyclic estrogen and progesterone. She will develop secondary sexual characters. She will start menstruating. ठीक है? But अगर blockage है, then you have to do a surgery. If it is a blockage, then the surgery is the answer. ठीक है? By applying a cruciate incision. Transverse vaginal septum है, surgical removal with anastomosis. एक बार blind और absent vagina का भी पूरा चार्ट देख लेते हैं, how it is evaluated. So if the vagina is absent, blind, whatever it is, patient will give you a history of secondary sexual characters present. Amenorrhea. So if it is obstructive, there will be symptoms of obstruction, like cyclical pain होगा. जैसे ही question write cyclical pain, either it is imperforate hymen or transverse vaginal septum. If there is no cyclical pain, secondary sexual characters present है, amenorrhea है, cyclical pain भी नहीं है, it is asymptomatic. Then it is either MRKH or androgen insensitivity. Look at pubic hair. Pubic hair normal, Mullerian agenesis. Scant pubic hair, androgen insensitivity. Simple. So this finishes our primary amenorrhea class. If there is any doubt, kindly write down in the message and I'll reply as soon as possible. Bye-bye.